Buenos dias, me llamo Moira. Thank you very much for inviting me to speak at your inaugural Stomacare conference. My presentation today focuses upon ostomy care in patients with inflammatory bowel disease. I have a conflict of interest to declare, as I'm employed by a stoma pouch manufacturer. However, I have a dual remit and my clinical knowledge is used to the fore, as is the case today, as my presentation is purely clinical. This presentation is available for you to collect from the Groby stand during conference, should you wish to do so. The content is then going to look at what is inflammatory bowel disease, what's the difference between the two diseases, and some common post-operative challenges. We first take a look at the definition of inflammatory bowel disease. It mainly focuses upon ulcerative colitis and Crohn's disease. Now, ulcerative colitis can be seen as a disease of the colon and rectum, resulting in periods of disease remission and relapse. And the objective sign is diarrhea. If we turn our attention to Crohn's disease, this can affect any part of the gastrointestinal tract, from the mouth to the anus, and can also be described as a disease with flares and remission periods. Symptoms for Crohn's disease often include abdominal pain, a loss of appetite, and the common objective sign is diarrhea or weight loss. If we take a look at inflammatory bowel disease as a group, the incidence of patient diagnosis appears to be rising in the recent decades, and this may be due to dietary concerns or as a potential thought of that. Typically manifests in the second and third decade of life, and although the pathogenesis is unclear, it is hypothesized that it is a chronic intestinal inflammation. Now, any inflammation is a problem for us when we come towards the healing of the surgical scar and also the management of the stoma with an inflammatory response. Inflammatory bowel disease is chronic, it's potentially disabling, it often leads to many hospitalized periods for the patient, resulting in a lower quality of life, potentially the inability for them to work. All of that results in substantial socio-economic impact. The medical management of inflammatory bowel disease is to achieve long periods of remission, and maintenance therapy is successfully used in many patients and manages to prevent disease flare-ups. However, if we take a look at the bowel itself, we can see that ulcerative colitis has mucosal inflammation, which typically starts in the distal rectum, showing progression towards the proximal colon. But in Crohn's disease, this is transmural inflammation that can occur anywhere from the mouth to the anus, as we've mentioned. Because it is transmural, patients with Crohn's disease may suffer with abscesses and fistulas. And in my wound care experience, this is how patients have often been diagnosed as having Crohn's disease, because of repeated abscesses with an unknown cause. Within Crohn's disease, there can be acute complications which require emergency surgery, often seen within 6 to 16% of this population. The types of surgical procedures undertaken for stoma formation is very similar to any other disease within the bowel. It depends where the disease is as to where the stoma will be formed, because the surgeon wants a good clearance of disease. However, this can be a problem with Crohn's disease because the disease management may reoccur further up the bowel. So in my experience, most of the patients actually have an ileostomy for inflammatory bowel disease management. Hallucin undertook a study, and within that group, 43 patients had an ileostomy. The main reason for that formation was actually ulcerative colitis or Crohn's. When we look at the skin disorders within the full study, we can see that contact dermatitis, granulomatosis cutis, fistulas and pyoderma gangrenosum are present within this group, and I've concentrated on some of these within the stomal complications. But before we get there, let's take a look at the post-surgical recovery and quality of life of these patients. It's been reported that patients who have had inflammatory bowel disease experience additional psychosocial barriers compared to patients who have their inflammatory bowel disease managed medically. Several studies, albeit with small sample sizes, suggest that patients experience substantial challenges with their stoma. And these have been listed as a decreased self-esteem, issues and concerns socialising. They feel a stigma when they do socialise because of their stoma. Lack of confidence with sexual intimacy, lack of confidence to care for the stoma by themselves, unacceptable body changes, embarrassment, pain and loss of control. And many of these are faced by patients who have a stoma, as we know when we complete the stoma quality of life score. However, these patients with inflammatory bowel disease have often been ill for a long time. Some of the post-surgical complications I've sharing with you today are common in stoma patients who've had a stoma for other reasons. But one of the concerns that I have is the inflammatory bowel disease itself. The patients are susceptible to any inflammatory changes, which often makes a standard care very difficult, and it's important to explain to the patients what they should be seeing around their stoma and things that if they look a little bit different, to get back in touch with the stoma nurse so it can be checked out. So looking at mucocutaneous separation here, the main aim here is obviously to prevent leakage of any fecal output getting down into the mucocutaneous tissues here, particularly for Crohn's disease, because we don't want any sources of infection getting in. If we move over to bowel obstruction, and again, inflammatory response dependent on what medication the patients are still taking, there are two categories really, aren't there? There's partial obstruction and a total. Partial obstruction can affect abdominal pressure. Patients may complain of their stools becoming very loose, almost diarrhea type with a foul odour. They may have abdominal distension and even swelling of the stoma itself. Total obstruction, on the other hand, is a total obstruction, nothing coming through the stoma at all, extreme cramps, abdominal distension, nausea and maybe vomiting, either of which we'd suggest that the patients actually refer themselves back to their stoma care nurse for triage, and if it's discussed that it's potentially a total obstruction, they present themselves back to their local hospital for emergency review. If we take a look at a retracted stoma, why would a retracted stoma be of interest in this group? Possibly because the patients will actually look at diet in a different way. If they're not constantly going to the toilet or afraid of having diarrhea, their dietary intake may change, and that can often affect where the stoma has been sited, its size and its shape, particularly if they start to gain weight. If they are losing weight, we would be concerned, particularly if they've got Crohn's disease, and a review would be undertaken. So it's often within this group that a soft convex product might be introduced and obviously observed. If we look then at stenosis, now stenosis is a different view for me. I would be very concerned around the outer stoma appearance, the mucosal membrane itself, any signs of inflammation, and again, particularly with Crohn's disease, because we may be presuming that the actual bowel has not really been defended against its inflammatory response from the body. So anyone with stenosis, not only do we need to follow normal protocol to dilate that, etc., but for me it's a bit of a red flag, I'm afraid. If we look at prolapses then, this is common for some patients, not for others. The reason I've put it on is really as a reminder that these patients have been ill for a long time and their abdominal wall muscles may not be as good as other patients preparing for stoma surgery. So certainly for us it's the use of support garments to try and prevent prolapse from happening in the first place. Granulomas are associated often with an inflammatory response, and here in the UK it's either powder and seals that are used to gently push that granuloma back down, or if it's affecting the adhesion of the stoma flange, perhaps a little bit of silver nitrate is used just to take the granuloma off. Same considerations for contact dermatitis and potentially candida around the stoma. Although not specific to inflammatory bowel disease, it's something to alert the patient to, and they may be concerned, particularly if they've had a fistula or an abscess before. And also from a nursing perspective, being able to distinguish between pyoderma gangrenosum and a fistula formation for these groups. Fistulas are the main concern that I've seen with inflammatory bowel disease, and in a couple of instances it was actually the development of a fistula and the review of the bowel that actually identified the patient had Crohn's disease in the first place. I did say this was going to be a brief whiz through, and my 10 minutes has already gone, but if you would like to find out any more, my colleague and I, Tessa Anders, we published in the British Journal of Nursing a case study looking at the management of a lady in her 80s with a chronic enterocutaneous fistula. I would just like to say to you all, gracias, and thank you very much for giving me the opportunity to present to you today, and I hope that you have a lovely and very, very enjoyable conference. Thank you.